On to Nutrition Rounds Live. This is our third session, and I will just go through a few slides and then hand it over to Dr. Wischmeyer for his presentation. So this is an activity of the National Board of Physician Nutrition Specialists. I want to first off thank the American Society for Nutrition and our supporting staff, Gwen Twillman and Dante Preciado, for coordinating and really helping us create this wonderful platform for sharing our ideas and thoughts about medical nutrition. My name is Daron Kahana. I'm the president of the National Board of Physician Nutrition Specialists, and currently with the Department of Internal Medicine and Pediatrics at the Los Angeles County Ambulatory Care Network. Today, we are featuring Dr. Paul Wischmeyer, professor of anesthesiology and surgery at Duke University. He's also the director of the Nutrition Support Service at Duke and an associate vice chair for clinical research. We are honored to have him and really thrilled to hear this case, which I think is quite exemplary of the benefits medical nutrition can offer our patients, inpatient and outpatient. We are featuring three wonderful panelists who volunteered to participate in today's session. Dr. Jill Cherry Bukowitz, who is a clinical associate professor in critical care medicine at the University of Michigan. Dr. Krista Haynes, who is not only the assistant professor of surgery, but I recently found out is also the chair of the ethics committee at Duke University Hospital and a colleague of Dr. Wischmeyer. And then of course, our past president, Michael Rothkopf, who needs very little introduction. He is currently the clinical associate professor of medicine at Thomas Jefferson University and also the Sidney Kimmel Medical College. And as I said, a past president of the National Board of Physician Nutrition Specialists. I just want to remind everyone that the application deadline for the November testing window is today. It may not be too late if you have any fellows or colleagues who are interested in sitting for the exam in November. The application process is rather quick and painless, and we would love to have more examinees sit for the November window. If not, the next window is right around the corner, and that's in May, June of 2022. So just real quickly, what is a physician nutrition specialist? So, and what are we as a board? The principal purpose of the National Board of Physician Nutrition Specialists is to certify physicians in the field of medical nutrition. We establish qualifications for such a certification and develop and maintain an examination to test candidates for their knowledge base in medical nutrition. We engage physicians who are interested in medical nutrition, and this specific nutrition round session is really an opportunity to engage physicians in that regard. We try to promote awareness among physicians and the medical community at large regarding the importance of nutrition in medical care. And then finally, our goal is really to advance the quality of healthcare that's available to the public through the use of medical nutrition. And with that, I will end and turn it over to Dr. Wischmeyer. Thank you for coming on to Nutrition Rounds, Dr. Wischmeyer, and I am turning it over to you. The floor is yours. Thank you.
Thank you. It's great to be here and great to be able to spend time with this esteemed group and talk about a topic that's, I think, near and dear to all our hearts, the role that medical nutrition can play to really change outcomes and save lives. And I want to tell you about a patient that I think exemplifies that as well as any patient that I've ever cared for. And so the focus of this particular case is the critical role that nutrition can and should play in surgical preparation, recovery, and ICU patient outcomes. So it's a surgical ICU patient. I'd like to call these my alignments of interest rather than conflicts, as I think I'm in alignment with the NIH and the other groups that fund the research that we do and in really trying to improve patient outcomes. So these are my alignments of interest. Actually, I need to add one more NIH funding. We just got a R01 from an ICHD for a rehab grant for post-COVID-19 rehabilitation that we're excited about, and I'll potentially talk about at the end. So I think the key message, right, that I think all of us in medical nutrition, especially those of us that do surgical nutrition for a living, is that no malnourished patient should ever have elective surgery without nutrition optimization, which of course includes nutrition screening. And I think this is happening every day, probably as we're sitting here around the country and around the world, where patient after patient is coming to elective operations significantly malnourished and significant risk for complications. And those complications could be largely avoidable if we did simple nutritional things with medical nutrition therapy. And I think the other piece that applies both to surgery and ICU, and really all our patients, is I think, as I round in the ICU or round in the hospital with my team, I always say it's just as important that we pay attention to the things we do today that help to get to the patient tomorrow as is the things we do today that are going to get the patient back their lives. And so I want them to be thinking every day about creating survivors of their patients. And unfortunately, in the ICU, especially with COVID-19 right now, there are times all of us question, are we really creating survivors or are we creating victims? Patients that perhaps will never go back to their families, will never leave a rehab center, or maybe will never actually leave the hospital despite leaving the ICU. Because ultimately what our patients, of course, want is to go back to the people they love so they can walk down the street with them again and hold their grandchildren again. And that's what we want to be getting back to our patients. And I think that's where medical nutrition plays such a crucial role. It's not just the day-to-day outcomes where it's also important, but also the lifelong quality of life outcomes. So as we think about surgery and preparing for any major stress, it could be cancer, it could be bone marrow transplant, or it could be major operation. This is the paradigm that we're teaching now, is that we have to train our surgery patients for the marathon of their lives. And for many of them, it truly is the marathon of their lives, as they're facing perhaps the biggest physical and emotional stress they'll ever face in their lives. And just like you wouldn't run a marathon without nutritional preparation, which is not so different than what you need for a surgical intervention, or exercise training, which is also a part of all this that we are interested in, nor should you be having surgery without training as well. Because although it may not be the marathon on the road, it is the marathon of the table. And the patient I want to talk to a bit about today, and I think is happening all too often in our patients, is what happens when we ask our patients to run the marathon of their lives for a major surgery without training. And that's where we get into the case. And this is a patient that I came to know very well. His name was Elijah. He's an 89-year-old who's coming for partial colectomy for rectal cancer. And he's already undergone treatment, chemotherapy and radiation for that rectal cancer. And so because of that, and because of the nature, of course, of GI cancers, he's lost a significant amount of weight over the last 3 months. He's lost about 10 kilos of weight loss over the last few months. And, when you talk to him and his family about what he was like as he came into the surgery, he feels weaker than he used to. But I think it's important to know that this gentleman was very, very active. In fact, the day before his operation, he was on the roof of his church fixing the roof tiles, or the roof of his church the day before surgery. So this is a very fit, very active, nearly 90-year-old gentleman coming for what is a significant surgery for a proctectomy and partial colectomy. So the real question is, he didn't get any nutrition optimization before surgery, unfortunately, and he goes for his surgery, and he does okay for the first 2 days after surgery. Unfortunately, on post-op day 3, he develops acute abdominal pain, and he develops rectal bleeding. And ultimately, he's rushed back to the OR where ischemic bowel is discovered. He goes into shock on the operating room table, and he has a cardiac arrest. And he gets a full round of CPR in the operating room for this cardiac arrest, and they restore circulation. But this is, as you can imagine, a big insult for someone who's nearly 90, who's already undergone cancer treatment and has already undergone surgery previous to this. And so, they found an anastomotic leak, and they found some ischemic segments of bowel. But ultimately that led to him having a cardiac arrest as well. And he comes back to me, and this is where I actually met him for the first time, into our surgical ICU at Duke, where Krista Haynes also works as well, who's one of our panelists. He's got an open abdomen. He's very weak. He has gotten poor nutrition, obviously, before the operation. He's already lost weight. And so he's at great risk. And so I began to get questions from the staff. Can he survive this? He's almost 90. Is he too old and too sick to recover from this? Maybe we should just withdraw care. This is just not something that someone like this can get through and perhaps survive at all. And Dr. Thacker, our surgeon at Duke, and I looked at each other and we knew what his family wanted, and we'll talk more about that. But we said, no, that's not what's going to happen here. This is someone who very much wants to live. He told us about how he wanted to see his granddaughter after he was done with his surgery, who we'd never met. He was really passionate about getting a chance to have a meaningful life. And so the family and the patient, ultimately based on his wishes, agree they want to keep fighting. And so remember, again, this was a very active patient. And so we decided we're going to fight for this patient. But the question is, can we save this patient and give him back his life? Because he doesn't just want to survive this. He wants to go back to spending time with his family, going back to his church and being active again. And so if that's going to happen, we have to be better with our nutrition and exercise and other interventions than perhaps we are now. But how do we do that? And the real driver of his risk of complications for this gentleman, who had really no other medical problems, was his malnutrition and muscle loss created a major risk of complications for him. And I think that's where this is really missed in the opportunities for what medical nutrition can do. And so nutrition was neglected for this patient. It was truly an emergency. And so we have to be better. And so I think a bit of understanding how many patients can be affected by this is how many patients are malnourished. And the reality is 2 out of every 3 patients like Elijah coming for surgery in the US right now or anywhere in the world. This is a really critical paper that Dilip Lobo published that really looked at sort of the data around surgical malnutrition. And 2 out of 3 are malnourished when they come to us, much like Elijah was. And I don't want to belabor all of you that know a lot about nutrition, but we know it's related to outcome. And this paper describes it well. If you come into a surgical case like Elijah did, and you have not lost weight, let's say you are well nourished, you're going to survive. You're going to do well. But if you have lost weight like he has, you have a 5-fold increased risk of dying. And so this is a major risk that patients take on when they come in without having a nutrition intervention and they are already malnourished, much like Elijah was. And again, the complication rates are dramatically different. If you haven't lost weight, you probably won't have a complication. But if you have lost weight, you're going to have a complication. And of course, he did, and a life-threatening one at that. So malnutrition is truly an emergency for our patients and one we can do something about. But we're going to need to do a number of things to recover people like this and optimize them. That includes personalized therapeutic nutrition, medical nutrition, rehabilitation, obviously, for someone like this who needs to recover and perhaps prepare. And then at Duke and other places around England and Australia, we're beginning to use Olympic athlete training techniques to prescribe exercise in a personalized way, targeting heart rates that they can do at home with iPhones and iWatches to optimize these patients to the best of our ability. And so I think that's really the key here, is that we can actually personalize nutrition, personalize exercise using tools and techniques that I'll talk about a little bit in this lecture, including metabolic carts that are now very pragmatic and very practical to use. There's a new generation metabolic cart that just came out last year that is a major advance in science and accuracy and usability, but also things like muscle ultrasound, BIA devices. These are things we're starting to use much more routinely at Duke, and we hope will be used around the world. And then CPET testing to guide exercise and recovery. And so I think one of the key steps is we really needed guidelines around surgical nutrition to guide clinicians about how to optimize our patients. And so I was honored to chair a U.S. and international, really, surgical nutrition guideline for patients having surgeries like Elijah went through. And this included surgeons and dietitians and clinicians of all sorts from all over the world that came together to develop these, and we published them a few years ago. And I think the things that we wanted to impress upon people, and this infographic was part of it, is that a large number of surgical patients like Elijah are malnourished, and they're 5 times more likely to die if they're allowed to go to surgery without this malnutrition being treated. And the reality is, we surveyed this. I did this with a medical student. We surveyed all of the surgical oncology and GI surgery academic fellowship programs at the big hospitals around the US. There's 120 of them. And only 1 in 5 have any nutrition screening process at all for these high-risk patients, which is devastating. But almost all the surgeons we surveyed said, we know medical nutrition improves outcomes. We just don't know how to get it to our patients, and we're not trained in medical nutrition to give it to them. And a lot of our nutrition intervention revolves around oral nutrition supplements, obviously, and we know every dollar you spend on those little drinks saves $52 in hospital costs. So it's very cost effective to do this. but we found only about 1 in 5 malnourished surgery patients ever gets them right now. And we've done some other data to back this up in modern, like recent practice as well. And so we wanted to make it simple for people. And so these are the 6 basic things we said. You have to screen people. Protein's more important than calories. You have to stop feeding late pre-op, so you can't make people MPO for long periods of time, and you have to restart the day of surgery in the recovery room. Oral nutrition supplements are essential to recovery and preparation for all patients. And then obviously oral before parenteral or enteral before parenteral. And then nutrition management is a team game. We need our IDs, our nurses, our pharmacists. Everybody's got to be part of this team. Surgery, anesthesia, medicine, everyone has to be part of this team to make it work. And so how do we improve this patient's nutrition? How could we have addressed him getting evaluated? And so I don't know if this is a good time, Ron, to bring the panelists' thoughts in, but or our participants' thoughts in, but what would you do to perform a nutrition evaluation for this patient? And then we'll talk about how we're doing it at Duke with a new screening score that we developed.
Yeah, so very well. Maybe we can use the chat feature, and if panelists or participants want to chime in and tell us, do you do any serological testing? Do you do indirect calorimetry? Do you measure skin fold or midway or waist circumference? What do you do, Dr. Rothkopf or Dr. Cherry, as part of your nutritional evaluation for pre-op patients?
Well, I wouldn't do any necessarily rely on any serum markers, but certainly a patient with this kind of weight loss would definitely set off some red flags for us. And we would also want to look at if there was evidence of muscle wasting. Basically going through kind of a GLIM criteria is the one that my personal favorites, looking at etiologic and phenotypic criteria for malnutrition.
Yeah, so what we'll do is if the surgeons are concerned about the malnutrition or just even optimization for patients that aren't malnourished, we have a program called MSHOP that we've placed together and have been doing some work with over multiple years, and have had really good results where it's really a quick, like almost like a pre-op marathon, training is what we kind of would look at it like. It is both nutrition, and it doesn't necessarily have to be supplements, but that is something that we can recommend. We found that some patients, it may be cost prohibitive to do actual nutritional supplements, and we've tried many different ways of trying to get that paid for, but it does become a challenge. The other is just helping them know what good nutrition is and getting them what they can do at home. So it's also then looking at it as a holistic view of the stop smoking, which is also, or at least reduction in smoking, then increasing activity. And it just has to be for a few weeks that these things can really make a difference. And that's what we try to do. And they get to talk to a nurse and a dietitian just by phone to get those things started. And it gives them ability to do something themselves that can help with their own outcome. So helping them take ownership, which is a partnership then with us as surgeons.
And I also have a comment from Dr. Dean, one of the participants and a director on the board, who expressed that doing a nutrition-focused physical exam and also gathering history about functional status and weight changes and activity level prior to hospitalization, where the delta between the baseline 2-3 months before and where the patient is at the time prior to surgery is very telling. And also, Dr. Abdel Hadi weighed in the chat room. Thank you for this very intriguing case for our pediatric population. The U of M nutrition assessment tool, is that the one that you use as well, Dr. Cherry? Is very helpful, designed by Dr. Buma, or not, I'm sorry, dietitian Sandra Buma from the U of M. So thank you for weighing in and offering your experience. Is there any benefit at all? You mentioned you wouldn't check any serological markers, Dr. Rothkopf, not even a prealbumin or any vitamin levels or protein levels at all. They're all
Well, I wouldn't rely on them for the diagnosis of malnutrition, but we do actually check zinc levels and iron levels. We find these patients, the elderly patients, have a lot of micronutrient deficiencies. And this patient has really protein calorie malnutrition, but even someone that doesn't appear malnourished is going to have a host of micronutrient deficiencies. You can almost assume that a 79, 89-year-old is in that state, and we would want to give micronutrient support there. But I wouldn't rely on circulating proteins as diagnosis for malnutrition.
Dr. Haynes, do you want to jump in as well?
Yeah, we pretty much do the same thing. And then sometimes we'll get out the indirect telemetry to try to figure out what their actual nutrition status is, because sometimes we're obviously overfeeding them.
Right.
Thank you.
So yeah, all those things are brilliant. And that's along the lines of what we do as well. Let me bring my cursor back. So we really sort of thought this was something that people were challenged to do, because when we did our surveys, we realized that there were a lot of academic centers, a lot of hospitals around the country that didn't have a simple, like, let's say, EMR based way to even begin to screen for malnutrition. Maybe not, you know, the GLIM, I'll show you the GLIM too in a minute. Of course, I'm all in for that. But we really want to develop something that was really simple that any hospital could adapt. And we actually have applied it in our cancer patients in the BMT clinics as well before they come for their BMT. But we started with this concept of, a little bit sounds like what Michigan's doing, where we have a group of preoperative nutrition clinic. We have a preoperative nutrition clinic that's run by an RD. And then we have a whole pre-op nutrition clinic network within Duke that has one for smoking, obviously, one for diabetes. We have a pain clinic, an anemia clinic, and then again, our nutrition clinic. And so the idea was that we were going to try to integrate a simple score, which I'll show you in a minute, that could be done by phone and by electronic medical record extraction immediately in minutes. And so we screen now all 60,000 Duke surgery patients by a phone screen that also draws data out of the chart. And we're also doing that pre-BMT for our bone marrow transplant patients. We're using the similar kind of score. And then we use a multidisciplinary model where we have an RD that staffs this clinic, and you'll see if they have a risk factor for malnutrition, they get referred to a dietitian who sees them either in person or by telehealth and puts them on a structured nutrition program that I'll show you. So, you know, it looks like this. I'm going to show you what we call the PONS malnutrition score that we developed and have now validated. And I'm not going to show the validation data today, but it's quite valid at predicting complication risk. And then that RD in the clinic can then pass that patient's information off to the RDs that will be caring for the patient on the inpatient side. And then the RD in that clinic follows them up post-op as well when they have nutrition risk. And so this is the score that we proposed in our guidelines and we've been using and we've been validating. And it looks simple. It's the things you'd imagine it to be. It's low BMI, which actually in our validation data is the poorest predictor of adverse clinical outcomes. Weight loss, which is among the best. And these are the questions that are asked on the phone. The others are extracted from the chart. And then have they been eating half of their normal diet? So this is going to look a lot like the ASPEN ADA malnutrition guidelines. And then we do use an albumin because it's such a robust predictor of surgical risk for complication. Although, you know, in the preoperative setting, it probably reflects malnutrition and inflammation state, of course. So it's not, again, as you said, I think perfectly, it's not a perfect score to itself for malnutrition. But what we want to do is get those patients in the door. We think they're at greater risk to see we want them to see an RD. Our validation data has shown is actually the greatest prediction for readmission, renal failure, and other things happens at a cutoff of 3.5 to 3.7. So in the next month, we're going to change that cutoff to 3.5 because we did our own internal validation in about 5,000 patients, and we found it works better. And so the other piece I'll just say about this, because I didn't include the slide, but NSQIP, which is a large surgical database, it's got about 2.5 million surgical patients in it in the US that the surgery folks in this call will know of, shows that of the top 10 causes of risk factors that lead to death within 30 days of an inpatient elective surgery of any kind, a low albumin less than 3.5 is the number 4 predictor of dying within 30 days. And so we've used that to equate to the risk of malnutrition. Again, we think it's tied to a couple of different things, but again, it's the only modifiable risk factor, if you can think malnutrition and albumin are modifiable in the weeks before surgery, that you can even think about modifying with nutritional intervention of all the risk factors, because there are things like cancer and other sorts of physical things you could never modify within the weeks before surgery. And so, but I think all of us are targeted to things you were saying, Duran, is that we need more objective measures. The idea that patients can reliably answer these questions and they're really objective in their nature, I think is someday going to come to an end. And so we've begun to look at, and we're not the only ones doing this, of course, look at the lean body mass by CT scan, which all these GI surgery patients get in their workups for lean body mass. And, we measured the L3 vertebrae. There's an automated slice-o-matic software now that does this automatically, draws out the muscle mass for you. You can do a measure in about 5 minutes. And in fact, I just learned that Mass General has a radiologist who's got a single slice CT protocol for lean body mass that exposes the patient to less radiation than a chest X-ray. And he is successfully billing, coding, and getting reimbursed from Medicare to do muscle mass at the L3 vertebrae with his single slice technique, which is a huge step forward. So we're actively learning to do that at Duke as well. And I won't belabor this, but we know that low muscle mass prior to any surgery of almost any kind predicts death and complication rates really quite dramatically. And this is where sometimes we miss the obese patient in our malnutrition screening, but they may have dramatic sarcopenic obesity and be at very high risk for surgery, and that they aren't always picked up on our traditional nutrition screens. And that's true in our cancer patients as well, where we know that the patient who has low muscle mass by CT, who's diagnosed with lung or GI cancer, will live an average of 8.4 months, and those that aren't will live 2 more years. And so I think this is really an indicator that we need to be more objective in our diagnoses. And so we've actually wanted to take this even to the bedside. And so we've moved to using an ultrasound technique to not only look at if patients are malnourished by muscle mass, but also we can measure muscle glycogen and see if our nutrition is working at the bedside. We can actually tell if our patients are eating what we've asked them to eat. And we can measure that daily if we want. And this is actually technology that evolved out of a Tour de France athletic endeavor, where they were using these ultrasounds to coach and to feed and to direct nutrition in Tour de France athletes. It's used by the Dallas Cowboys and the Colorado Rockies and many other professional sports teams around the world now. So the device was actually developed by Inigo San Milan, who is a exercise physiologist I worked with at the University of Colorado before I came to Duke. And so now we're using this technology. It's been incorporated obviously there. And so forgive my dog. But we found that lean body mass by ultrasound is something that can be done at the bedside. And now there's a device that's a very specific muscle mass ultrasound. And it actually can do what is essentially a muscle biopsy via ultrasound and tell us what the muscle glycogen is. And it changes muscle glycogen into color. Water follows it in, and actually the darker purple areas are higher areas of glycogen and the lighter purple are lower areas. And so we can actually even do and understand what the muscle glycogen is. And it's a probe that looks about this big, plugs into your iPhone or your iPad, and can give you data in minutes about muscle size, muscle quality. So it can measure intermuscular fat and muscle glycogen, which tells you if your patients are eating what they're saying they're eating. I'll show you some data from that perhaps later. But then we also use BIA at times too. And this is GLIM. This is a table from the GLIM criteria. And these are cutoffs that are suggested, and we're trying to develop our own for actual objective measurements from the BIA that can be used from objective measurements from BIA and we believe from CT scan and ultrasound as well. And so we think the future is this is the kind of information we need to be using to diagnose malnutrition objectively, and that we need to be adding this to our scoring systems and to our risk diagnoses. And so again, as you mentioned, the GLIM criteria, I think, are really the future of malnutrition diagnosis. And they have a whole category in the phenotypic criteria related to muscle mass as measured by one of these assessment methods. And I think that's going to be really critical in the future. And so we're going to add this to the PONS score when we have enough data to say we can reliably do that. So this is Elijah in the ICU, and what were his muscle and body composition measurements like? What does this actually look like in practice? So this is what his BIA measurements look like. He had lost a fair bit of weight. He had a lot of body fat, but very little muscle mass. And so we were able to measure that. And this is what it looks like by ultrasound, by the ultrasound device that we were using to blow that up. This is the fat layer. This is the muscle layer. And actually you can see how light purple that is. There's really no dark areas. He had a very low muscle glycogen. And that's something we could talk about another time, what the different numbers mean, but his was very depleted. And so in the ideal world, could we have done something before surgery for this patient to treat it? And so I guess it'd be interesting to hear from the panelists and the participants, what are you doing now when you identify someone who's malnourished? What are you doing to treat them and prepare them for surgery?
So first, one of the questions that came up from Dr. Dean is, how soon prior to surgery is it advisable to do our assessment? Do you want to do it immediately before, a week before? What's the ideal time frame?
In a dream world, a month before, to optimize the amount of time we have to intervene on people. But we actually just got data back a few days ago from what our average time is. Our average time to referral to our RD nutrition clinic is about 24 days. So they get referred typically on the phone screen, which happens right after surgery is scheduled. Sometimes they get referred directly from our surgeons' clinics themselves to the RD, to the clinic. It takes a little while to get the appointment because the RD now has really skyrocketed in the last few months, and we've been running for about a year and a half, but we really have improved our scheduling, and she's seeing about 60 patients a month now. And so it takes a little bit to schedule. So our average time for scheduling to surgery is about 12 to 14 days, which we do think is sufficient to make a difference. We'd love to have 4 weeks on everybody, but we're averaging about 2 weeks on most patients, which is enough time, our data would say, and I'll show you that data in a minute, to make a difference in outcome and really change outcomes for our patients. But that's the window, the bigger the window, the better, obviously. But I'm curious if anyone out there has specific interventions they're using before surgery for the malnourished patients. Do they have specific pathways they follow? Or
Jill, does the University of Michigan have anything they use?
Well, it's not specific for every patient. It depends on if you get referred to the M shop, and that's the majority of that. Unless.
Oh, you're muted.
Oh, we muted.
Mhm.
Yeah.
Sorry, my computer has been very touchy today. Yeah, so what we do sometimes, like if you have one of our GI patients, especially if it like they happen to be getting an esophagectomy, they actually may require preoperative like tube feeds or even TPN depending on the patients. So it depends on a lot of different aspects, but for just the regular general surgery patients or even the oncology patients that don't have specific needs, that's when the M shop would come in.
And for us, I mean, I work in a cardiothoracic unit, so the
Yeah.
pre-op, the lung transplant and heart transplant patients are seen by the transplant dietitian, and they're prepped and prepared. But we also have a lot of patients who just come in acute myocardial disasters. We had a patient with a ruptured myocardium last week, you know, so things happen so quickly. There's no prep time. We've seen, you know, really serious myocarditis from COVID, and they literally come in after collapsing on the street or in the car or you know, something like that. So there's that dichotomy. But the patients who are going for heart transplant or lung transplant are prepared, you know, in great detail.
That's great. So at Duke, we created a pathway, and this is the pathway we published as well. So we do our PONS score and we do our malnutrition screen. And if they're negative, what we suggest to our surgical colleagues is they go down the low nutrition risk pathway. So if we see them in pre-op, or if we can get our surgical colleagues to follow, in the peri-op period, 7 days before they have surgery, we recommend immunonutrition for all the patients because that's not related to malnutrition. That's a separate mechanism. And then carb loading the morning of surgery with a complex carbohydrate, and then immunonutrition for 7 days after, and a high protein HB containing ONS. And there's a reason for that too that I'll show you the data for. And that's what our low nutrition risk patients, we recommend ONS after surgery for every patient. And that was part of the guideline. That was this, except for screening, that was the strongest recommendation that our group of surgeons and anesthesiologists and dietitians made in our surgical nutrition guidelines. The patients who do show nutrition risk, the ones who are much more likely to be malnourished, that have weight loss or other things, they get referred to the clinic, and then they get started on a high protein H&B ONS for 4 weeks if we can get 4 weeks. Usually it's more like 7 to 10 days. And And then they get the Seminutrition, the carb load, and then they get the Seminutrition afterwards, and then the high protein ONS for 4 weeks after. And then the RD follows up on a weekly basis. And this is where a lot of her busy, she sees 60 patients, new patients, but then she's doing these follow-ups weekly too with all her patients. And she follows them weekly to assess compliance, answer questions, make sure the patients are able to follow through with the things, and also talk about their diet. And so this is the structured pathway we use. And we have a QI right now where we've been sending some of these supplements, or all these supplements, to the patients for free. Now, that's not all our patients. Not every patient qualifies for the QI, but we're hoping to find ways to try to continue that. And some hospitals have succeeded, University of Indiana, University of Pittsburgh, they give the Seminutrition and the carb loads for free as part of their ERAS programs. And then clearly, this is what we drive home to the patient, that protein is much more important than their calorie intake, and they need to reach a protein goal. Our dietitians teach them to do this and really try to emphasize protein-rich foods and ONS. And then we are very strong believers in the oral nutrition supplements for at least 7 days, whether it be Seminutrition or high protein ONS. We like Seminutrition 7 days before, but if they have longer, we lean on that high protein ONS. This is part of our guidelines. And again, I won't belabor the data. This is just one example, but there's all kinds of data showing that 7 to 10 days of oral nutrition supplements prior to an oncologic surgery or any major surgery, in most cases, can really reduce the risk of all kinds of complications. In this case, surgical site infection was reduced 2.5-fold just by doing this for 7 to 10 days. And that's where we try to get that time window from, is studies like this. And then clearly, like you heard Joel say, that we have patients that clearly can't take the oral that we need them to take. And this is always a question I ask a lot of sort of non-medical nutrition knowledgeable folks about starting TPN. And clearly, this is a great recommendation of almost all our nutrition guidelines, that preoperative patients who can't take in at least 50 to 75% of their protein and calorie needs need perioperative PN. And we do a lot of this at Duke. And again, this is the other message I always am trying to drive home. And I can tell you the new FASPEN guidelines are going to say that TPN and enteral nutrition and critical care are equivalent. That's going to come out in a few weeks. Although it's already been shared. And when we know from large randomized trials in very sick patients that it's just as safe to put TPN through a central line as just saline through a central line. And so this is a huge education deficit we have found in sort of the non-nutrition verse practitioners. And so we've really, Krista's played a big part of this at Duke for us, really trying to drive home to our surgeons that TPN is not something that they should wait to start. It's not something they should be afraid of. And of course, lots of reasons for that. These are the things we're teaching people, that, all those studies that showed infection risk were done before hyperglycemia was controlled, like when I was a resident. And we didn't treat till glucose was 300 or 350. I had cardiac surgeons tell me it was a great diuretic, let the glucose ride to 350. I mean, that was a really different era, and that wasn't that long ago. But all these different things play a key role. And the other thing I really try to teach the centers I speak at is they need to be switching lipids. They need to switch. We finally, for 20 years, we have advocated and fought and legislated to get new IV lipids in the United States, besides just the omega-6 lipids. And we finally succeeded in that in 2017. And so I really try to drive any hospital system that is not using an olive oil or fish oil-based lipid to change now. There's really robust data for infection reduction from that. So, and then the Seminutrition question that generates a fair bit of controversy, surprisingly, still, despite the robust data that really shows that 5 to 7 days of these immunonutrients, and what that means is a supplement that contains arginine and a little bit of fish oil before surgery. They reduce infections 40% in thousands of patients' studies. And again, this is not related to malnutrition. This is an evolutionarily conserved pathway that we as humans have to shut down our immune system after 3 days, because, of course, if we got attacked by a tiger 3 days later, no one was coming to operate on us. And so the body didn't want to kill itself, but there's myeloid-derived suppressor cells that sort of are generated from exhausted neutrophils that deplete arginine in our spleen and lymph nodes and shut down our T-cell immune response. And that is something all of us experience, malnourished or not. And so my group and many groups have done meta-analysis on this, but we showed that in 3,000 patients, 32 trials, that this reduces infectious complications 40%. And this is a $20, $30 intervention, reduces length of stay by 2 days. And this is in all comers, malnourished or not. And these are in our meta-analysis. There's larger meta-analyses since ours was published, but this is a major effect. And some of these are large studies published in very good journals, high impact journals like Gastro and others. And it works if you give it preoperative only. It works if you give it pre and post-op, and it works if you give it just post-operatively. And it works in GI surgery patients like Elijah, and it also works in cardiothoracic, ENT, and other patients as well. And so it isn't particularly specific to the kind of surgery you're having. Much larger meta-analyses have been done since ours. This is a 7,000 patient meta-analysis that was in a high impact surgery journal. And the reality is this isn't everybody. So specific studies have been done in well-nourished patients and seen the same benefit, but the only people who are going to teach patients to do this really are people who have medical nutrition training and passion, I suppose. And so we really push this. If I was having surgery tomorrow, I would do this. And, when my mom has surgery in a few weeks, when she has a redo valve surgery here at Duke, she's already planning to do, she's already doing things like this. And so I would say, do I need to tell you any more? This works and we should be doing it. Unfortunately, so few people know this data that when we survey practice, less than 1% of patients are receiving these inexpensive, effective formulas. And so that's, I think, a real challenge to our specialty of medical nutrition. And we have to be better than that. And unfortunately, this patient did not get that. We didn't have these pathways in place when this patient had surgery a number of years back here at Duke. And so they weren't getting it. And so then again, the next question is, would you give a carb load? And for time's sake, I'll move forward a little bit because I think the data is pretty strong for this. And again, unfortunately, Elijah didn't receive that because we weren't doing this in all our patients yet. But there is robust data for this, and it's a key part of ERAS. Those of you doing ERAS, I hope all of you are. And the recommendation is 45 grams of a complex carbohydrate, and that's essential. And that's the piece I'm going to tell you why. It's not Gatorade, it's not orange juice. It's a complex carbohydrate, so you need a specific formula. That's the only thing that's been studied. And the data is quite robust, actually. So in major abdominal surgery patients, this couple dollar drink of complex carbohydrate reduces length of stay by a day and a half. It also reduces vomiting, it reduces pain, it reduces anxiety, and reduces other complications. It reduces nausea and vomiting as well. So there's all kinds of advantages. It's not like carb loading for a marathon, you're carb loading for the surgery. But there's specific ways it has to be done to be effective from what we can tell. And again, it's a complex carbohydrate. We encourage patients to take 100 grams a night before, much like a marathon runner would take. That's what they do in the UK and other major ERAS countries in Europe who've been doing this longer than we have. But it needs to be a 12% complex carbohydrate drink, low in osmolality. And that's key to gastric emptying. As an anesthesiologist, and that's my training, we care about gastric emptying. We don't want patients to aspirate. And that's why orange juice and Gatorade aren't necessarily safe. The reality is they are not complex carbohydrates. They don't have any maltodextrin, and they have a much higher osmolality, which potentially could delay their gastric emptying. And so if a patient aspirated with Gatorade, you wouldn't be able to defend yourself in any court because there's no data for that. And all the data that does exist uses this complex carbohydrate drink showing gastric emptying and safety. The other key thing is it has to be drunk over about 5 minutes, because what we're trying to do is prevent insulin resistance. If it's sipped over a few hours, that doesn't work. Franco Carli, who's a real leader in our field of perioperative nutrition, has studied this and found that patients who sip it don't get any of the insulin benefit response. It has to be taken over about 5 minutes. And so we have to teach our patients how to do this right. And so this is really critical as well. And it's not something that, until I learned it from Franco, I didn't know this either. And so I think most of us would never know this. And so it's really key to coach our patients to do this correctly. And then the other piece is, again, it's really important that gastric emptying is maintained for those of us in anesthesia to prevent aspiration, which can be devastating. And that's why we don't want simple sugars or the sports drinks or orange juice. And so the last thing I'll say is there are some drinks out there on the market, and the idea has been floated for years that maybe we should have protein or amino acids to these pre-op carb drinks. The problem with that is amino acids like arginine and other high nitrogen amino acids induce nitric oxide and delay gastric emptying. And so Franco Carli and myself and others have said there should be no amino acid in there, especially citrulline or arginine, which is the popular ones you see put into some of these drinks. They should only be complex carbohydrates because they could delay gastric emptying, lead to aspiration, and that would be devastating. And so they shouldn't contain, at least the 2 hour before surgery one should not contain amino acids or citrulline or arginine. And then the real question we get a lot of is, what do you do with the diabetic patient? This is the most common question I get when I present this lecture to surgery folks. What do you do with the type 2 diabetes, which virtually feels like all our surgery patients have? And so we recently, Rafat Higazi, a name you'll know, worked with 2 PhD RDs and reviewed all the literature that exists on this subject. And we just published it actually about a week ago. And it showed that pre-op carb loads in type 2 diabetes, there are some small studies out there, and they seem to be safe. The gastric emptying seems to be similar, which is one concern. The pre-op rise in glucose is pretty minimal. It's not too dramatic, and it doesn't seem to be an issue for preventing surgery or being a complication for surgery in type 2 diabetics. And it doesn't seem to increase risk of complications like nausea and vomiting. In fact, one study showed it reduced the length of stay in diabetics who got it. So we need larger research studies. This is a big area of controversy in our field, but it looks like the initial data says this is safe and may be beneficial. and is something that a lot of the big ERAS centers like we at Duke are practicing. And so this is a common question that we get. And so again, this is something we should be doing, but again, very few people are getting it, unfortunately, compared to how many should be getting it. And so it's something I think we have an opportunity to do better with. So again, you know, he goes to surgery, Elijah goes to surgery. And what about after surgery? What should we be doing? When should we be feeding patients? And maybe I'll ask the panelists, do you have a sense when your surgical teams are feeding patients? Are they starting getting fed in the recovery room? Is it day 1? Is it day 3? Is it bowel sounds they're waiting for? What has been your experience?
Yeah, I think we're mostly seeing, you know, not day 1, you know, maybe day 2, certainly by day 3. These are mostly cardiothoracic patients.
Sure.
Yeah, and so for our general surgery patients, trauma patients, burn patients, it depends on the patient. So the burn patients, I should start with, we actually feed through the operation for anyone that has a post-pyloric drop-off tube
Great.
without a ET tube, or with a, I guess, an airway that's already secured. And so those patients get constant feeds. If they don't have that, we try to start it immediately, as quickly as our residents can put it in, and that's where the delay sometimes comes in, is when do they realize they need to restart the feeds. We actually have, at least in our trauma burn ICU, which is what I run, the patients actually get mad and put in risk reports if we don't get their family member fed immediately, because they're so used to it. But then the surgical ICUs are different. It depends on what we're doing it for. So anyone with a potential of having mesenteric ischemia because of low flow, then we do it's a much slower route to starting. But patients that are from like an acute issue, whether it be like a transplant, you know, liver transplant, renal transplant, those patients get fed pretty early as long as they're stable. The same thing goes with patients with like a bowel resection. We wait as long as the NG tube is low, then it may be closer to 1 or 2 days, depending on the surgeon too and what they saw in the operating room. So it's a wide variety of what we see. We try to, again, trauma patients, we try to get up and running very quickly because they're in usually our trauma burn ICU. We're always thinking about the nutrition because of the burn patients there too.
I think that your measurement of the muscle glycogen would be really important. I mean, we're assuming that a patient, you know, day 0 has a couple of days of glycogen stores, and or at least one good day, and you know, so we have a day or 2 to convert over. Maybe start a trickle feed, a gut trophic feeding, you know, at the end of the first day. But you're right. Some patients come in and they're really, you know, they are malnourished and they don't have that reserve, and it's really hard to tell who's who.
Yeah, for sure. And we've made some measures actually of patients after trauma and after sepsis and other illnesses with our muscle glycogen measures, and we actually find that within 24 to 48 hours of a major trauma or even sometimes just a major surgery, their glycogen levels will drop to 0. Which is more than a marathon runner would drop after a marathon. It's devastating. The athletic people who developed this technology had never seen anything like it. But they never measured an ICU or a surgical or a sepsis trauma patient before. And so it's devastating. It takes about 7 to 8 days to recover, even when fed. And then it begins to climb it's interesting. It probably signals the transition out of acute phase, we think. And on another day, maybe I can show you some of those pictures because you really can see it change when they start to recover.
And I hate to do this, Dr. Wischmeyer, but we have several directors waiting for our monthly conference call. And so this is a fantastic talk, and I think we need to continue this conversation in a more didactic webinar, which we will be launching as well in the upcoming months. But maybe for the purposes of the last few minutes, we can fast forward to the resolution of the case, and and just kind of get a sense of how things went with your intervention.
So he ultimately got his belly closed and was extubated quickly. He was quite actually fit for his age. And so we started him on a high protein ONS with HMB, and that comes from the large NOURISH trial that was published, actually that Rafat Ghazi and others worked on, 76 centers, 650 patients, showing reduction of post-hospital mortality by half in patients who got it and significant improvements in muscle mass. We ramped his protein up, obviously, to 2 grams per kilo per day. I am a robust user of testosterone cypionate and oxandrolone. I used to be a burn intensivist myself for many years in Colorado and Chicago. I don't have oxandrolone routinely at Duke. We don't have a burn center. I can only get it for my cardiac transplant patients, where I guess pharmacy will do anything for them. But I use testosterone cypionate and I measure levels. So I do that routinely. We start a creatine for him, which I do in my patients who are really motivated. We corrected his vitamin D. Of course, he was quite deficient, and we know vitamin D is essential to muscle mass recovery. And he was very motivated, and his family was very motivated. And so, hold on a second, it's not, and then we got a really aggressive physical therapy program started for him that included walking and chair sit to stands. He had his own exercise bands in the bed. His family brought him his own dumbbells that he exercised with in bed. And he really committed to doing this and to drinking his supplements and to taking in everything else. And he walked out of the hospital 28 days later on his 90th birthday. And this is actually him holding his weights in his room as he's recovering on the floor. And I stayed in contact with this family for quite a long time. He lived another 18 months. He was independent. He went back to church. He went back to doing things around his home. He met his granddaughter, and he spent 18 meaningful months and passed away peacefully in his home on his own terms with his family about 1.5 years later. But he got the time he wanted and was able to live the life he wanted to live. And so I think ultimately that was the key for him. It was really recovery of his strength and recovery of his quality of life. His medical piece turned around quite quickly, but I think the thing that so often is neglected is the medical nutrition piece. And I think the other key to this story is a lot of these complications, maybe all of them, could have been avoided or at least minimized had we done better pre-op nutrition for him. And I think that's the other key message. And so I think those are the key takeaway points. And I think, you guys said it well, that surgery creates this teachable moment, like a surgery school, where patients will stop smoking, they will treat their diabetes, they will change their diets because they're facing this incredible challenge to their life. And we found in our exercise and nutrition programs, they continue to do it after their surgery. They want to keep exercising, they want to keep eating better, they want to keep supplementing if they're doing that, because they're facing this challenge, and it changes their lives forever, we found. And so I think it becomes a real opportunity to teach people things that otherwise they'd never do, and shows the value of medical nutrition to be for a lifetime. And so again, I think we can prepare people for this marathon. I think I always tell my residents and trainees that it has to start with us. We have to endorse this too. But we can do better, and we have pathways to do better. And we've published a paper that describes how we implemented our multidisciplinary preoperative nutrition optimization clinic. This is freely available online. And so it has posters that we put up in the surgery clinic, and it has pathway diagrams and all that's free online. And so I think really the goal is to do this in a personalized way. And this is a paper I wrote about the real personalization I think nutrition needs to go in the future. And it includes use of metabolic carts and the new metabolic cart technology, and BIA's muscle sound, and CPET guided exercise, which is sort of the cardiopulmonary exercise testing athletes do. We do this in our rooms with a Bluetooth mask in our patients now. And these are the basic nutrition goals that we try to achieve. And I won't belabor these, but these are the things the pathways we routinely follow. And then this is how we implement our indirect calorimetry in those patients. And so, I think we want to have patients in surgery really never be fed the same way that they have been, and have much better optimization and evaluation techniques. And so that all patients will have the chance to be best prepared, and ultimately we'll get them a life worth leading afterwards, and take patients who look like this, which is what Elijah looked like, have them walking on their vents, which we're actively trying to do even our COVID patients, and then have them eventually look like this, and maybe leave the hospital looking like this even, at least like this. So I think that's really the dream. And then I always encourage, everybody to follow. If you don't have a Twitter account, get one. It's the best way to keep up with the literature. And I share lots of the new medical literature, nutrition on Twitter and Instagram. I also will say, if you really want to reach a lot of dietitians in the US and worldwide, they're on Instagram, and there's no better way to reach our dietitian colleagues than sharing evidence and things they can use in their clinical practice on Instagram. And then Twitter clearly is where I think most of the physicians I interact with live. So.
Well, thank you so much, Dr. Wischmeyer. You
Thank
are
you.
truly a champion of patient care. And I think it's not just knowledge that you bear, but really the passion comes through in such a meaningful manner. And you are speaking to a group of physicians who are equally passionate about medical nutrition and truly believe in the impact that a nutritional approach to medicine can have in the lives of our patients. And there's an old biblical saying in Judaism, when you save a person's life, it's as if you've saved the entire world. And I think your case presentation really depicts that and exemplifies the difference we can make even in one person's life, and how much more meaningful it is than just a single person. So thank you. And again, I'd love to continue this. I know that you have a lot more information that we need to study and to utilize for our patients. So we need to learn from you, and I apologize for cutting you off a little short for this particular discussion. And I want to thank our panelists as well. That was an excellent discussion. Dr. Haynes, Dr. Rothkopf, Dr. Cherry, that was really helpful. And our participants as well, Dr. Dean, Dr. Abdulhadi, who participated, Dr. Park as well. People who used our chat to ask questions and make comments. So thank you, everyone. And we will continue this in 3 months. For now, we're only doing nutrition rounds once every quarter. But hopefully in 2022, we will start a CME webinar. And Dr. Wischmeyer, I hope you don't mind, I will try to hit you up again and dive a little bit deeper into this topic.
Thanks, Paul.
To answer the one question, guys, that I saw, Doron, you asked about bleeding risk with SMOF. We haven't seen that. There isn't a lot of fish oil in SMOF. It's only one of the 4 components. And so it's something we use routinely in our surgical patients. Krista has a really neat protocol where we're starting our open abdomen gunshot wounds or other open abdomen bowel discontinuity patients on TPN on day 2 within 48 hours of admission.
If we anticipate them not being able to tolerate PO for like 7 days.
Right,
Yeah.
which almost all of them don't. And so we have never seen any issues, nor have I seen anything published that would imply that. So I think people could feel very confident in using that in their surgical patients.
Great. And we're going to go ahead and sign off here and then actually rejoin. And Dr. Wischmeyer, you're welcome to join us as part of the monthly conference call for the NBPNS, and Dr. Haynes as well, or we will circle back around in due time. So thank you again. Thanks, everyone. What a pleasure.
Bye-bye.
That was